Thanks for joining us again here at the Neurolog Academy. We're talking about neurology again, functional neurology, and one of the main things is if you hear neurology, don't think Parkinson's, dementia, all these things firsthand. Think neurology, think neuroanatomy, and think all body systems and all types of dysfunction. So that's the most crucial aspect of understanding functional neurology. So very often I get asked, well, what do you treat, like neurological disease? No, I treat everything because I believe that everything could have, all symptoms could have a neurological aspect to them, and that's what we have to find out, how big is that aspect. So what is the nervous system doing? Well, it's gathering information and it's putting it together. So there's a whole bunch of single informations coming from all parts inside the body, the parietal system, the visceral system, but also, of course, outside from the body, visual, auditory, smell, all these things. These things need to be put together so I can behave appropriately and my system can adapt to the environment I'm living in. So if it's hot outside, my body should work different than if it's cold outside, and if it's light outside, and if it's dark outside. So all these aspects matter, and it's a system in the context of the world. So there's two aspects to that. Part of it is autonomic. So if I get up, it doesn't really matter if I get up here in Munich, in Murnau, Bavaria, or if I get up in some other part of the world. My body's going to have to adapt. The pressure system, my vascular system has to adapt so I don't collapse when I get up. So that's going to be the same thing wherever I'm on the world, but the circumstances might be different. So maybe I'm in one part of the world I'm happy, in the other part of the world I'm not happy, and that will influence the way my system is working. So maybe if I'm not happy, I might collapse because my interoceptive system, my visceromotor system is not working properly. Okay, so context matters, but there's autonomic systems working, also movement systems. We're going to be talking more about that, movement patterns after the summer break in the fall. So what we talked about so far is peripheral receptors, and the way we went through that is not exactly the way I work with patients. That depends very much on what they are having, or they are telling me what they have, and maybe the causation I see in what they have. So if somebody comes in with a knee pain and he tells me he hit his head severely maybe a few weeks earlier, I'm not going to start with the knee, so I'm probably going to start with the head, because it's very, very likely that the head is part of that if the knee pain came after the head injury. So if it's the other way around, of course the head might not play such a big role. So that will make a different approach to what I'm looking at than if something he's telling me I got hit in the leg or had a surgery on the leg. I'm probably will start with the leg or with the knee, because there might be some receptor issues, some nerve issues, some vascular issues in the periphery, in that area that I want to get fixed. So peripheral receptors, nerve tissue. Nerve tissue, of course, is the one that's transporting the information, but it's also tissue. So it has biological qualities. It needs energy. It needs oxygen. It needs some energy supply to burn into ATP. And also it has mechanical properties. So a nerve has to have a sympathetic innervation, and a nerve also has to have a proprioceptive innervation. I don't know if that's described in that way in any textbook, but that's basically what it is. So if I'm stretching my nerve, my brain has to know that my nerve is being stretched, because the nerve is going to get damaged if it's overstretched. That's what happens if I go over the capacity of the nerve to extend itself, and then I can cause permanent damage in the nerve. So this happens, and this of course has to be monitored. So anything that can get broken needs to be monitored by the nervous system, telling me then, whoa, stop, don't go further than that, because then the next thing is your nerve is going to get damaged. So that's with all the tissues. So there we have like the nerve transporting the information, which are going through the receptors, and at the same time it has mechanical properties because it's a different aspect if I do it there or if I do it here. So that's nerve function or nerve innervation, the innervation of the nerve itself. Then we go to the spinal cord. We talked about that, integration of different parts of the body, left and right. So there we go, like with movement patterns, what's the right leg doing, what's the left leg doing? That's something that's happening on the spinal cord level. And next to the spinal cord, you have the autonomic nervous system. So if I start moving my leg, not only does my left leg want to know what my right leg is doing, so the movement can be synchronous, but also when I start moving, my muscle will need more energy, more oxygen supply. So you have an exercise pressor reflex, which is probably going to go through the paravertebral ganglia up to the heart. That's the way it's described now, to tell the heart pump more. And this is not dependent on oxygen or CO2 levels. This is just dependent on movement. So movement will initiate autonomic change because the brain already knows, well, once I start moving, I'm going to be needing more oxygen very soon. So I don't have to wait until I need more oxygen. I'm just going to start working because it's going to happen anyways. And if I slow down before oxygen supply is becoming short, well, then the heart, of course, will slow down too. So you can do this just by moving your arms. You will raise your heartbeat right away, your heart frequency, to get more oxygen where it's needed or where it's going to be needed. So those are autonomic aspects, and we're going to be talking about those more in the fall. So this is spinal cord. The central for me is also an autonomic part, but an autonomic part of the somatomotor system. This is not the way it's officially described, but that's the way I describe it, because that's where I believe movement patterns are mainly located. So we know that there are central pattern generators, like for walking, and I think also other movement patterns are generated mainly in the spinal cord and just modulated by centers high or above to adapt the basic program to the actual need. So that's what the brainstem is probably going to do in an integrated way for the whole body, and then the cortex is going to do, is going to say, well, I just don't want to walk straight because there's a lot of obstacles I can see, so I kind of have to go around the obstacles. I have to adapt my basic movement or my basic gait pattern. So that's where the brainstem comes in. So that's integrating different parts of the body, integrating proprioceptive somatomotor function with interoceptive and visceromotor function. And the top of the brainstem, the mesencephalon, you already have an integration with the environment. So you have information from the environment, auditory, visual information from the environment coming in, and you have basic integration or movements toward a stimulus. So if you hear something, your whole body is going to align towards a stimulus, and that stimulus might cause something with your autonomics, because maybe that stimulus signals danger, and then here you go, you breathe more, your heart rate goes up, your blood sugar levels goes up, etc. So that's what's already happening in the brain stem. The more differentiated visual input is going to be in the cortex, because you just have more cells to process the visual information. That's what it is. It's a higher resolution. So maybe if the brainstem, I don't know, has 0.5 million pixels, maybe your brain has 20 million, 30 million, 100 million pixels. So there's more resolution, so you can react in more detail to what's going on. The first reaction is just watch out and maybe try to get out of there. You'll jump out of the way. If you see something before you can even think and see what that actually is, you're jumping away from. So cortex is just a more detailed moment-to-moment adaptation of your behavior. That's what the cortex is. And in between the midbrain areas is where more the referral to your experience comes in. So you have the hippocampus, which is managing your memories. You have the amygdala, which also manages memories in terms of, was that dangerous last time or even not dangerous? So it's not only danger the signal coming from the amygdala, it's just evaluating the situation. Base ganglia also doing that more with like a reward aspect. Oh, that last time that was really good, so I want to do that again. That felt good, that was successful. And also hypothalamus, of course, in that part of the brain has basic programs of behavior, like feeding, like reproduction, all these things. So that's like a database I'm working with. So I have all the things coming in from my body, I have the things coming in from the environment, the information, and I have a database which is not only in the midbrain areas, but that's where you can say that's where it's like managed. Maybe that's the right term for that. So all these things come together, and they have to work together, and they have to interconnect, and they have to integrate. So that's what needs to be done, and that's what we're basically doing. And I have my son here today, and I'm just going to show the way what it looks like to integrate. I already showed it a few times, but I just want to show it again because basically it's very, very simple. It's a very, very simple technique because I'm not the guy who knows all the information. That's basically impossible to know how much force needs to be applied to what muscle to get a good movement going. The body should know that and should learn that. But if it's not able to connect basic systems in the body, that's not going to work. So before we start worrying about content, movement content, we have to fix the basic the basic parts, and fixing the basic part for us means getting them back to connected. So we have a network, and we have brain networks, and we also have body networks, and we have brain-body networks that we have learned. And if I have learned how to move in a certain way and I have a severe head injury, I might forget part of that, or the system gets disconnected. So that's what we know about in the stroke research, that the problem arises from the connectivity systems. So the white matter, that's where the music is playing. So if the white matter is damaged and the systems cannot connect, that's where the function is not doing well or not going well. It's not so much the cortical area that's related to a certain function, it's the connectivity between different systems: cortex, midbrain, cortex, brainstem, body, or spinal cord, body systems, whether it's a muscle or it's an organ. All that needs to be connected, and that's what we're basically doing. So the technique is simple. The hard thing is understanding all the accesses to the different systems, to the different brain areas. So there's different way of accessing them by touching certain parts of the body, by doing certain functions. So we have different tools we can work with to access different brain areas. If we can't get to them by just simple techniques like touching certain parts of the head or the face or the body, then we have to try to go through or tackle the problem with a functional testing. So that's basically what it is. And once I found the problem, once I could locate the problem where the body is not reacting the way it should react to a certain behavior or stimulus, then we can think about, or then we can look for something to fix it, which is basically putting another piece of the puzzle into the interaction to get that into a normal function. So that's what I'm just going to show again. So my son Maxi is here, and I'm going to ask him over to the table to so we can work a little bit, and I'm just going to talk you through this to explain what I'm doing here. And like I say, very simple, basic technique we're using, but still the results. I'm not allowed to say what the results are, but I'm working with this since 18 years. I've probably done 30,000 treatments plus, a lot of patients, a lot of things I've seen, and yes, well, let's just get going here. So what I'm not going to do, of course, what you do with the patient is you ask him about his history. So I take a very exact history of where his complaints are, why, when they show up, or under what conditions they show up. That's, of course, I do all that. I do a lot of neurological testing, basic testing like walking, stability, vestibular testing, balance, all these things. I'm doing that. I'm looking at the eye movements. I'm looking at body movements, of course. I'm also looking at the autonomic nervous system. And one thing, this is probably the hardest part to look at because you can't see something. Of course, you can go here and you can feel the heart pumping. That's basically it. And you can feel when he's breathing. But bowel movement, like the osteopaths say they have like an intrinsic movement of the bowels. We do that a little bit different. So there's quite a bit of intuition I'm using after 18 years of listening and observing and touching the body. There's a quality in the to get the information that's a little bit different from palpation. So if you palpate, you kind of look for, I don't know, tightness in the muscle or something like that. When you test, you look for movement. When you muscle test, you look for for facilitated or inhibited muscle, all these things. If you look at the visceral stuff, you kind of have to get a feeling of it. And this is something, of course, you can learn. We teach that in our seminars, actually. We teach them how to listen to your own body when you interact with the body of the patient. So I'm just going to say hello to everybody listening. Thanks for watching. Thanks for coming by. And here we go. So Maxi, let's just assume he came to my practice and he told me what's going on, and I did all the examination. And very often I would work lying down, just because that way I can test a lot more with the legs, and I can test the body, palpate the organs, things like that. So that's not very easy to do that standing up, but of course sometimes you have to work standing up because a problem might not show up here. So if there is a problem like in the fascia of the glands, and now the glands are all lying, the organs are all lying more to the back, and the problem might not show up because there's nothing pulling on the nerves or on the tissue. So this could only show up maybe when you're standing up. So of course you have to think of that. You cannot treat everything lying down. It's impossible. But you can treat a lot lying down, even if it's related to standing up. You can do that. So this is the best way of treating most of the body systems, or looking at the body systems also lying down. And when I say looking at, like under a neurofunctional aspect. So I don't know anything right now. We just had a session in German, so I already did 2-3 integrations. That's what I'm going to do now. So I'm just going to look. I'm just going to have a look, and I'm just going to try to find out if we can find something that he needs to get integrated. And usually everybody that is engaged in life and does sports, like my son, he plays soccer. So I don't know, you get hit in the leg, you get somebody goes on your foot, or you try to get a ball with your head and you're not hitting it right, and that could cause some kind of distraction or dysfunction in the nervous system of the head. So very funny thing, I think that a lot of treatment just kind of ends, I don't know, maybe in the face. So there are people treating jaws and things like that. I don't see anybody treating eyes, so I always look at the eyes. I always palpate the eyes. I see how well do the eyes move, because if I watch somebody and I do some smooth pursuits and I see the eyes not moving correctly, that could be due to a bad efferent system, so maybe cranial nerve 3 or cranial nerve 6. They're not firing correctly, but it could also be due to cranial nerve 5, which sits in the eye proprioceptively, and so maybe the proprioceptive system of the eye is not working correctly. And I've done a lot of correction on those things, and then watched the eye movement, and there you go, the eye movement is just perfectly fine. So don't always think cranial nerve 3, 4, 6. If you already think neurologically, for example, with the eyes, also think cranial nerve 5, because that's the proprioceptive part of the eye. So all these things need to be looked at. And of course the head, I said that in the last part 13, I talked about the skull, the head, the cranium, how important that is, because the nerve that's in the cranium coming from the inside, the cranial nerve 5, the trigeminal nerve, also innervates blood vessels of the extrinsic system. So that's the blood vessel system that's on the outside of the brain. And if you have a dysfunction in that nerve, which you can maybe access through a suture, then you might get a dysfunction in the vascular system, causing dysfunction in the brain tissue, causing dysfunction in the body. So I've seen that a whole lot of times. Somebody coming in say, well, my leg is not working right, I have hip problems, knee problems, everything like that. Then you start looking at them and you start seeing, well, it's not so much maybe or it is a functional problem maybe of more central part of the nervous system, but you start looking at the nerves or the skull, you see that there's a problem with the skull, and there's nerves there, and those nerves are attached to blood vessels, and those blood vessels are attached to the brain. So they're already doing tests now, accessing, for example, brain tissue through the cranial nerve 5, the upper part, the ophthalmic nerve here, or the ophthalmic ramus here, by putting electrodes on that. And here you go, if you put an electrode on the forehead and activate that nerve, you will get a different blood flow in the brain. So that's connected to each other, and that's why you have to take a very close look. So I always look at the head, and that's what I'm just going to go through. I'm just going to quickly kind of go through his body to find out if we can find some dysfunction in his system. So I believe that he has a dysfunction somewhere in the dura, and that's we access that through C2 because there's the myodural bridge. I hope I said that right. It's a very strong connection also with muscle tissue attached to C2, to the dura that is there to, so when I incline my head or when I move my head, so that the dura does not collapse, it can be just gestrafft. So now I'm looking for an English word, which is, I remember in German, of course. So it tightens the dura, like all the small muscles in the joints that tighten the joint capsule so they don't get in the way and they don't get pinched. So there's no impingement. So this part of the dural system is very good to access problems in the dural function. So maybe this is not the best thing to show here right now. I'm just going to keep on looking to see what else I have. So here in this part of the neck, so if I go right here, okay, that's of course is a little ticklish here. So so palpating this, and I'm here probably on his blood vessels. So blood vessel dysfunction is very common in all parts of the body. It's muscle tissue. So if you have somebody who's complaining about, I don't know, a sprain or a soreness or something, don't always think just muscle or fascia. Now fascia, of course, is very popular right now. Also think blood vessels, also think nerve tissue, of course, but blood vessels. So very, very often somebody coming to me said, I had all these treatments, I have all this fascia treatment and mobilization and all that kind of stuff. And that helped me some, but it didn't resolve my problem. Very often I find blood vessel issues because which part of the body would you innervate very tightly or very strongly, because it can cause a lot of problems if it gets damaged. So if you have damage to your muscle, you're not going to die. If you have damage to your nerve, well, you could die because maybe you can't run anymore or something. If you have damage to your blood vessel, if it's a big one, you might be dead within a couple of minutes, okay? So I believe that the innervation and the hierarchy, so meaning what is very important to the survival, well, blood vessels must be right up there, because there's points where you can get right to the blood vessels, and if there are big ones and you puncture them, you get them injured, well, there you go. Maybe that was it, okay? So, a lot of protective mechanisms. So people not being able to turn their head, yes, that could be muscle, yes, that could be this and that. Could be vestibular system, could be eyes, because retinal slip is not tolerated by the brain, something like that. But it could also be the saying, well, somebody's pulling on my carotid right now, so please don't pull on the carotid because I don't know what's going on there. And this could happen like after whiplash injury, for example. So I had a patient coming in the other day. He was a young guy doing a lot of sports, wanting to go in professional sports, and he got hit in the throat, in the neck, and he had vertigo. He had problems seeing. He had you could say interoceptive visceromotor problems with his energy, all that kind of stuff. And his blood vessel on the left side of the neck from the internal carotid, or from the common carotid, or carotid communis, arteria carotis communis. So this was all messed up all the way down into his arm. All those parts of the vascular system were dysfunctional. So if you went there and you irritated them, the body would just go blank, I want to say. So let's do that. So I talked enough, now we're going to do something. Okay, so what I need first is some kind of reactivity from the body. So of course we use a lot of muscle testing. So I get a lot of criticism, not me personally, but I always read and hear, well, muscle testing, how exact is that? Well, it's not very exact. It's not a science, okay? But it is good enough to get reaction from the body, sensory motor reaction. So how else do I want to test for the sensitivity of the vascular tissue, or the nerves in the vascular tissue? How else do I want to test for that? Yes, I can palpate that by now, saying, well, there's something wrong right here, but I want to find something that helps me to find a solution, because I don't want to find the problem only. So let's just start right here. He has no problem holding his arm right here. So now I go onto his blood vessel right there. So I'm pretty far up, so I'm on his internal carotid right there with my middle finger. I can feel the pulse. I give a little bit of pressure, not a lot. Of course, you don't want to press there because there's sensors there, and you can just get the blood pressure down, especially if you have elderly people. Also, they might have some calcification in the arteries, so you don't want to be pressing down on them. too much just palpating the pulse. So you think, oh, he's got pulse, so he's alive. Okay, that's fine. So now I just have my hand there, and I just see if that irritates something. Okay, so that's not going to do anything at all with him. So he's fine if I touch that. I still have the impression from my palpation that something is wrong in that area. So now I start connecting things and see which way does that go. So where is that artery coming from? It's coming from below. So it's coming from the heart. So there is connectivity between all the vascular aspects of the system, the big vascular aspect and the central aspect of the vascular system, which is the heart. So you can just go on the heart and hold the internal carotid. So nothing there. So one aspect of innervation is here the cervical ganglia. So I always go to the cervical ganglia and I check that connectivity. So I'm just looking for connections of nerves, also the medial, so nothing there. Now I'm going up into the head. Of course I cannot go into the head, but usually it's enough if I go somewhere on the head to find a connection. So there it is. I touched his internal carotid and I touched his forehead. So I'm just going to touch his forehead now. I'm not going to touch his carotid. So touching his forehead is not going to do anything. So it's not going to change anything with his motor output. Touching his carotid doesn't change anything with his motor output. Touching both at the same time. Just put down your arm for a second. So touching both at the same time. So now I'm on his carotid, now I'm on his forehead. So is the forehead, if you think inside, if you think inside of the brain, is the forehead or the forebrain, the prefrontal cortex, is that supplied by the carotid, internal carotid? Of course it is. Yeah. So is that what we're testing right now? Maybe, we don't know, but that's just what we have right now. Fact is, if I touch his carotid, nothing happens. If I touch his carotid and his forehead, something is happening, and we need to fix that. Okay, so there's a lot of assumptions we need to make about what does that mean, because we don't know. We don't have a measurement of the anterior cerebral artery saying, well, if I touch this and this is going to affect the blood flow to the front part of his brain. Maybe it does, we don't know, but we could assume that this might be the case. Okay, so I have people coming in after stroke, I have people coming in after head trauma, and that's exactly something I find. I find a problem between the part of the head that got involved in the crash or that got hit, and different aspects of the autonomic nervous system going through that part of the head, and part of that system is the vascular system, of course. So here I go testing again. I'm just going to do that again, see if it's still happening, and it's still happening that he has less strength in his arm. Okay, so I'm not going to do anything at all. Okay, hold very strong. So he's very strong when I do that. Okay, so something is changing. All right, and all we need to do now, besides thinking about what this could mean, but which is not going to lead us anywhere right now, we need to fix this problem by giving him a solution. So what we used to do way back when I learned this first, we used to just integrate something like this. So we found a connectivity problem. So we touch two parts of the body and the brain is saying, what is going on? So that's probably what's going on here. The brain is saying what's going on, and his parts of his output system, part of his motor system is going weak. So that is showing some kind of change, and we don't even want to call it a problem. It's showing us some change by interacting with the system. Is this change normal, you might ask? Okay, so let's go to the carotid on the right side. So now I'm on his right carotid, and I'm going to test this side. So nothing's happening here. So now I'm going to go on his right forehead, see if something's testing here, or something's changing here. Now I'm touching the same thing on this side, the internal carotid on the right and his forehead, and that's changing not at all. So you might wonder, why is it not changing here? Why is it changing on that side? Yeah. So going back to this side, well, here we go again. He's going weak again. Okay, so this could be repeated maybe now 100 times, which is not going to bring us anywhere. So now we need to fix this problem. So what we need to do now is activate some other part of the nervous system to get that reaction resolved. Okay, so you can always try to look at it in a very logical way. So you're thinking, well, brain stem, what's innervating here? What is this? This is the carotid. Very difficult to go on that with vascular system because it's very complex innervation, cranial nerve 9, cranial nerve 7, cranial nerve 5, a sympathetic nervous system, and then also from the inside to the outside, the ascending reticular activating system, which is not ascending, by the way, only it's also descending, and it's not only serotonin and norepinephrine and all these. It's a whole bunch of things, not so much described in the textbook, so that's a very complicated system, but so this is not a way to go at it logically. So what we do is we go through it systematically, okay? So we try to find a solution systematically. So what that means, I'm touching the 2 points of his nervous system that seem not to integrate, that seem not to work together, or that when we stimulate them at the same time, the body's saying, I don't understand this, okay? So I might just go to his brain stem, which is when we go here under the jaw, this is something that correlates with functions in the medulla. So I'm going to try that, see if that changes anything. It doesn't change anything at all. So I'm going to go here to the side, which correlates for us with functions of the mesencephalon. So going back to that and testing that again. So that doesn't change anything. So I'm going to the back of the head. So that's where the cerebellum sits. And I'm going to do that again. So now I'm just testing through that, and I'm just going to speed up the process. I don't have to. I already found something that takes away the inhibition. So now I change something again. This is where we integrate, okay? Integration, very simple. All you need to do is you need to activate the skull, tap on the head, whatever that is doing. We have absolutely no clue, but it's been working for 30 years, that this activation will help the system to integrate the connectivity between the systems you've just been using. So I have the back of the head, I have his internal carotid, I have his forehead, and I integrate that. So I have 3 parts of the nervous system, and I'm putting them together. Why this works, like I said, nobody has a clue, but it works. Okay, so here we go. This is the integration process. So this is basically very easy because you just repeat touching or activating the different parts of the nervous system. So here we might have cranial nerve 9, here we have maybe cranial nerve 5, and then we have in the back of the head, we have the back of the skull, of course, but we also have the cerebellum sitting behind the skull. And on the inside of the back skull, there's cranial nerve, not cranial nerve, there's parts from C2 and C3 coming up to innervate the dura, also going to the vascular system. So there you have interconnectivity between the different systems, which you can use to go from the outside to the inside, because the outside of the head is also innervated by C2 and C3. So this is how you get from the outside to the inside. So we did that. Now we just have to go back and test the same thing again, see what's happening now. And there it is, it's not showing up anymore. So I cannot irritate his nervous system by touching 2 parts of his nervous system, one part on his carotid and the other part on his forehead. So this is already quite specific, going to the vascular system like this. I'm just going to try to show something that's maybe more not so specific, or it could be specific, but maybe you could relate more to it because it's somewhere in the parietal system. So I'm just going to go through and see if I find something maybe in his joints, okay? So just looking at his joints, just trying to see. So maybe he has something here, just go through the rib cage. Okay, he's ticklish. Yes, he's ticklish, okay. So maybe the pelvis is something we could use, okay? So let's just test his leg right here. Hold very strong, okay? And what I'm just going to do is I'm just going to activate his pelvic bone. Yeah, just going on his pelvic bone. So we have the sclerotome, so nothing happening there when I activate that, okay? So now I might push it back, okay? So I'm engaging the SI joint right now, pushing it back, yeah. And hold very strong. So nothing happened in there. And now I'm pushing it forward. So what I have to know here is that this is normal, okay? So because when the pelvis is going forward, this correlates with extension of the leg, all right? So it inhibits the flexors if I push the pelvis forward, because this goes together. When I flex my leg, my pelvis is going back. When I extend my leg, my pelvis is going forward. So this needs to work in sync, and it does. So if I push the pelvis forward and I test the leg and the flexors get inhibited, that's normal. That's physiology. So nothing to do right there, all right? So I could do some other tests like functional tests. So that's has a lot to do with patterns, with movement patterns. We're going to be talking about those in the fall when we pick up the NeuroThursdays again after our summer break. So movement patterns, very big thing to know movement patterns, because I see people pushing around and say, now it goes weak, there is a problem. Say, well, that's not a problem, that's a physiological function, because right here now we're in external rotation or internal rotation that correlates with extension or flexor tension or whatever it is. So you have to know movement patterns, of course, to evaluate that. So the other thing which I always talked about is I can test function, see how function impacts other function, or I can test pathways. Yeah? So what I'm going to do now is I'm going to say, well, this is, what is this, L1, L2? Okay, so what I'm going to do now is I'm going to activate the upper part of the lumbar spine and the pelvis at the same time. So I'm going to just go up here. So this is like 4, 5, 4, 3, 2. So I'm up at the upper part of the spinal cord. I'm just going to activate the skin a little bit right there. So I'm going to see if something is happening when I do that. So I'm activating the skin. Nothing is happening. So put down your leg again. Now I'm activating his pelvis again, and I'm activating so I'm kind of testing the connectivity between the spinal part, or more of the spinal part. Of course, we're not at the spinal cord level, but we're kind of more in the interaction between the periphery here and the central part here. Of course, I'm not touching the spinal cord. I'm going through the dorsal ramus, but that is kind of giving you an idea, or the thing that's in my head now is, there's more of a peripheral central interaction. So this is testing, okay? So doing it again. Just waiting for the sensory system to calm down. So I'm on the pelvis. I just touched the pelvis. Okay, so nothing going on here. I touch the back. I touch the lumbar spine. No, I touch the lumbar spine. Go on the skin, irritate that a little bit. So there's nothing happening here. So I touch both of them at the same time. So I'm giving 2 inputs, one here, one in the back. Here we go again, saying, well, connectivity or simultaneous input is difficult for the brain, so the brain is saying, well, I don't understand that. Or is it? Maybe this is a normal pattern. So what I always do when I'm not sure, could this be normal? I test the other side. So I go back to the spine, I go back to the pelvis, this time on the right side. I have the 2 same contacts, hold very strong. Nothing happening here. So, well, which side is correct now? Is this side correct or that side correct? Well, maybe your patient is telling you because he's saying, well, I have trouble with my left hip or my left back or with my left SI joint and not with my right SI joint, okay? So here you would assume that, well, then the mistake must be right here. So now we want to look for a solution. So this could be very simple because there's a strong connectivity between spinal parts and the brainstem, lower brainstem. So very often what you would find is if you do this and you go on the spinal cord and then you go up here, which is something we use to activate the medulla or lower brainstem, well, this is going to change it right there. So all you have to do now is integrate it. So simple. Touch, 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 integrate. Yeah? So I activate this, I activate the spine, I activate this, and I activate this. So I remember my son getting hit on the pelvis in a football game, but I think it was the right pelvis. But I'm not sure. So maybe he will tell me about it later on. Okay. So done. Integrated, test, and see what's happening now. Well, there you go. It's not reacting anymore. The reactivity has changed. And what is very interesting, what I see a lot every day, this is happening every day. I'm just going to say hello to all these people coming by to say hello, hi, there we go. So I see this a lot. So when I touch this, it could be that this part would be like more irritated. He's saying, well, here I have more pain on this side than I have on this side. So when I do this and I do this, they're saying, well, that feels different, okay? Because the nerve is irritated or the nerve is excited or whatever that is, whatever you want to call it. And the thing is, after you integrate it right away, usually or very often right away, this will feel different because the neuronal or the nerve activity will change immediately. So that's usually where you can see not only the problem the patient has, like, I don't know, bending over or walking or whatever, but activating the nerve changes quickly, or the activation of the nerve changes quickly. And that for me is always a sign of, wow, I've changed nerve activity. Because now when I hit the pelvis or when I push a certain part of the body, the pain is less or the sensitivity is less, which tells me, well, we've modulated the nervous system right there, which is going to change the way the system is working overall. So let me check my watch, and we are just doing fine. And that's what I wanted to show again today. And I just want to repeat, this is how simple the treatment is. So the hard part is understanding all the single parts, understanding all the parts of the brain. How do I access that? The hard part is understanding why the person maybe has a knee problem, but I have to integrate his utricle on the left side. That's the problem. So that's why I have to have a lot of knowledge, and I have to have a lot of. I have to do a lot of testing to find out what do I need to integrate. In the end, it's not only one integration. Usually, if somebody has a problem, there's a whole bunch of mistakes in the system that have accumulated. So I have to get rid of those. So it's not like I integrate one thing and then he gets up and say, oh, pain is gone now. Sometimes that happens actually, but usually it would be like, if I do this now, I might have him stand up, the patient, and he's saying, well, the pain has gone down like maybe 10%. Sometimes they say, oh, it's gone down 40%. Sometimes it's only gone down 5%. So then you find the next problem, the next tract, the next neuronal tract that's dysfunctional, and you integrate that again. So this is the thing. It's and I keep repeating that you don't have to make it complicated right away. In terms of, I have to understand all these details about movement, all these details about biochemistry, all that. It's quite good if you kind of know what this means, because the patient might ask, well, why is that important for my body function? Why is cranial nerve 8 or cranial nerve 5 important for my body function? What does that have to do with my knee? Because if you say, well, it's not the knee, it's your cranial nerve 8, you have to have knowledge to explain that to the patient, because that's what he wants to know. He wants to understand the causation or the causality or the interaction between those systems. So that's what knowledge is good for. But basic treatment, or the treatment technique, is just, I think, quite simple, because you're just connecting the dots. That's what you're doing. You're just connecting the different parts of the body and the brain, for the brain networks, for the body networks, for the body-brain networks. So that's what you're basically doing. So I'm not going into a chat today because I need to get home a little bit earlier today. And I'm going on summer break now. We're going on vacation or into summer break quite soon. So I'll be back in September with NeuroThursday. But I think I might change the format a little bit. I'm going to be doing this also live, also with background with treatment. But I also want to do some more anatomy, some more science. So I'm probably going to split that up, and maybe, I don't know if it's going to be live. Part of it's going to be live, so I'll probably be doing Neuro-Thursdays live once a month. That's my idea right now, but I could change my mind when I'm coming back from vacation. So I'll let you guys know when we're going to be starting again, around mid-September, probably, most probably. And what we do want to have quite soon, maybe even this year, is some more in-depth introduction to neurofunctional integration. We will be start to translate all our approach, or the whole system, into English, into the English language, to start having that available in English by next year in our online academy, with the material, with the manuals, and of course also with video. So that's our plan. We don't know what's going to happen, so that's just the plan, all right? But I'm happy that you joined us. This was part 14, and we're going into summer break. I already said that, and I'm saying that again because I'm looking forward to it. And I hope to see you guys again. So thanks for coming by. Thanks for watching this video. We have this also on our YouTube channel. A bit better quality than on Instagram, but of course a lot of people watch on Instagram. Thank you for doing that. We have quite a few clicks on our videos here and also on YouTube. So the idea of neurology in medicine is spreading, and that's what it needs to do. It needs to get out there because the brain is part of the body. We can no longer ignore it unless somebody's saying, I have a neurological problem. Well, every patient should say, I might have a neurological problem. Can you fix that? All right. See you. Thanks for watching. Thanks for stopping by. And I'll see you after the summer. Bye-bye. Have a nice summer and see you soon.